The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So essentially the background, you all know this, I don't need to tell you that, what the Met does, what calling criteria are and so on. So if you look at the problem as such, only 1% of patients admitted to a hospital actually die during that admission. 10% of ICU patients die. If you have a Met, the mortality is about 30%, but the literature to us showed that if you have a Met for decreased GCS, about half of the people die. So, and this was based on a study that Darrell and Ronaldo and Downey did and reported in Critical Care Medicine. So we decided to study this again and to compare, to do a retrospective study after ethics approval and have a look at all these things in an organized fashion. So we did a retrospective database review using our Med database, which is a very mature database now, using the ANZICS core database and our patient administration system database, and use appropriate statistical techniques. So this is what actually happened. So we had roughly about 4,000 meds, of which 660 roughly were for decreased GCS and the rest were for other causes. And then we analyzed that further and looked at patients who are admitted to the ICU and not admitted to the ICU, separated them as to the calling criteria, ICU admissions, no ICU admissions, and looked at their mortality, which I'll talk about a bit later. So if you look at the early bit, so there were about 600, like I said, who had decreased GCS, and the others who didn't have a decreased GCS, who had met calls for other criteria. And if you concentrate on the ICU admissions, there were only about 39 of 660 who were admitted after a decreased GCS to the ICU, and the rest were for non-decreased GCS admissions. And if you look at the mortality at this point, you'll see that about 50% of patients, again, who have a Med for decreased GCS and get admitted to ICU die, whereas if you have a Med call for other criteria, your mortality is roughly about 30% or so. So quite a stark difference. So if you have a decreased GCS and are admitted to ICU, you've got a 1 in 2 chance of dying. So we then decided to do some baseline to look at the patients a bit more, and we looked at their age, and roughly that was similar. The gender was similar. The amount of time you spent on the Met call. So you could, the median was about 30, but it was between 1 and 70 minutes, and about the same for both. So it isn't as if you spend a lot of time with Met calls that have for decreased GCS as opposed to other causes. And if you looked at the location, if you look at all comers, so the stroke and neurology, neurosurgery ward, so they are the ones that account for a decreased GCS. If it's not for a decreased GCS, then it's more cardiology and respiratory. So that's quite expected. But then when we go on to ICU admissions, most of the ICU admissions for decreased GCS seem to come more from cardiology, coronary care, or from the renal ward, as opposed to the stroke, neurology, or neurosurgery and plastics ward. So really this is quite different from what you'd expect. So these are not all patients who are sitting on a stroke ward with a stroke and then aspirate or something or come to ICU. At least in our hospital, it looks like most of the decreased GCS patients coming to ICU come from cardiology and coronary care. So if you look at ICU admissions, as I said before, about a 50% mortality as opposed to a 30% mortality for other causes of ICU. Again, if you look at decreased, look at the patients who are admitted to ICU, there's not much of a difference when you look at their demographics, so the age, the duration of Met calls, the length of hospital stay, and the male-female ratio. Again, we looked at their physiology at the time of Met call, and if you look at all comers, obviously the ones that didn't have a decreased GCS had a Met call for other reasons, and so their respiratory rates were higher or their blood pressure was a bit lower and their SATs were a bit lower. So this is quite intuitive, so it's not something to really be worried about. We looked at antecedents for those who had met calls for decreased GCS, and only about 40% had antecedents. And the most common antecedent was a clinical review call. For those of you who are outside of New South Wales, in all of New South Wales there's now a two-tiered med system where you have a clinical review call where the ward doctors are called before you have a med call. But it's not always if you hit the med criteria, so there's kind of the between the flag system in New South Wales has a red zone, which automatically means that you get a med call and the ICU team arrives, or you have a yellow zone where the inpatient team is called and they look after the patient. And at the moment, roughly the rates of clinical review to med calls are 1:2, I think. There's 2 CRCs for every med call that we see in kind of at least at Liverpool Hospital. So really, some had decreased SATs, some had fever, some had sedative drugs. But the most common thing was they had a clinical review call. Maybe the inpatient team saw them and then decided to involve the med team. 24-hour antecedents, quite importantly, in the 24 hours prior to a med call for decreased GCS, a significant proportion of patients had sepsis that was diagnosed. So what the med team recorded in decreased GCS meds, so the med team leader recorded that there was a CNS cause for the hospital admission in only about 1/3 of patients, whereas in 2/3 of patients, the med team leader actually said that the hospital admission was not due to a central nervous system type of cause. And at the time of med, the decreased GCS was recorded only in about half the patients. So in half the patients, maybe the ward nurses recorded this GCS wrong, or by the time the team arrived, the GCS was back to 15. So if you look at the ICU admitted patients, so the previous slides were for all comers, but if you look at the ICU admitted patients for decreased GCS, now this is what the med team records for their, when they arrive at the med. So only a small proportion of patients, they recorded a med diagnosis that was related to the central nervous system, and almost no patients had a hospital admission that was related to strokes or other causes. I mean, there's a small, like a cerebellar hematoma, so there's only 1 or 2 there. So this is all 39 patients. So I mean, what this really means is, if you're admitted to ICU with a med call after a decreased GCS, it's very unlikely that you have a CNS diagnosis. Most of the diagnoses are not related to your central nervous system. Again, looking at 30-day survival, you know, there's a wide separation. If you have a decreased GCS, you're more likely to die at 30 days, as opposed to if you have a med call and are admitted to ICU for a non-decreased GCS cause. So if you look at the hospital outcomes, again, as we said, 50% of patients die. We looked at the Apache 2 SMR, and the SMR was 1.7 if you had a decreased GCS and were admitted to ICU, and it was 1.3. So clear separation again in terms of the SMR. We looked at the age, and we found that if you are less than 65, about 78% of patients survived if you didn't have a decreased GCS, and 22% died, whereas if your age was more than 65, this is starting to look pretty similar. So again, if you looked at survival and non-survival about in the ICU patients with a decreased GCS, the non-survival, or the ones that died, they had a higher Apache 2, Apache 3. Their bicarbonate was low, so they were acidotic. Urine output was low. Their hemoglobin, hematocrit, everything was low. So they're a much sicker group of patients when you looked at them that way. So those not admitted to ICU, so this is the group that's not often captured, and that's the one that we are trying to capture and do more work on. When we looked at the diagnosis-related group, The most common diagnosis-related group, as you expect, was CNS-related. The hospital mortality was 32% for those with decreased GCS, whereas for those with med calls who remained on the ward, the hospital mortality was only 11. So about 3 times as many patients die if a med call is called for decreased GCS in hospital as opposed to those med calls for other criteria. So whether you are admitted to ICU or whether you're not admitted to ICU, a decreased GCS is a sign of kind of something bad going on, and you're 3 times as likely to die, or about 30 times as likely to die as other patients in a hospital. So there's only one previous study, as I said, and comparable outcomes there. There were a few ICU admissions from our neurological wards. There were few neurological primary diagnoses, and only 20% of patients had antecedents. So the higher mortality, we saw that although they're more common, although you get more med calls for decreased GCS from the neurology and neurosurgery wards, ICU admission is more common from cardiology and coronary cares, and there were no neurological primary diagnosis in patients admitted to ICU. So what this really means is, and why we studied this and why it's important to report this, is that GCS can only be measured clinically and not by machines. So if you're going to start having automated track and trigger systems, you might miss these patients. Decreased GCS is associated with more mortality than other triggers. Sepsis may be an important cause, and we are looking at the QSOFA and so on. We'll probably report it later from the database. We can look at education and local management in neuro wards to avoid the med calls from neurology and neuro wards for this. Some of the patients may benefit from treatment limitation orders initiated on the ward. So there is a role for some feedback to the wards, some treatment limitation and other things. So we need to feedback and educate. This is just an observational study that we're still kind of completing the study, so there's not a lot else that I can report. But there is, decreased GCS. If you have a med call for decreased GCS, all we can say from this study is that it's a sign of badness. A lot of patients die from this. And we need to be looking at this area a bit more and reporting on it a bit more. So happy.